Hi, everybody. Thank you for joining us for today's Musculoskeletal Health Australia webinar. My name is Kay, and I am a member of the team here at MHA. Musculoskeletal Health Australia would like to take this opportunity to acknowledge the traditional owners of all the lands from which we are joining the webinar today and pay respects to the traditional owners, elders, and custodians of these lands. So some brief housekeeping. If any of this webinar raises questions or concerns for you, please make sure that you give the Musculoskeletal Health Australia back pain, arthritis, and musculoskeletal conditions, or as we like to call it, BAM helpline, which is free to call on 1800 263 265. You can speak with one of our highly qualified healthcare professionals and receive support and information that you might need. Today's webinar will provide research on a topic that affects all of us and is very much front of mind, that is diet and nutrition. We know that our diet choices are important, but sometimes pain overrides nutrition and can affect our food choices. Dr. Susan Ward is going to present her findings and some practical takeaway messages based on her PhD research, which looked at how do dietary patterns and adiposity influence chronic musculoskeletal pain. Susan completed her PhD at the Alliance for Exercise and Nutrition at the University of South Australia, and her research interest focuses on the impacts of nutrition on human physical health and functioning. And that stemmed from having worked as a clinical physiotherapist before returning to studies in this field. So Susan's PhD has combined her foundational knowledge in a cross-disciplinary approach to explore how these patterns of diet and adiposity influence chronic musculoskeletal pain. So Susan is very much well placed to provide us some information on this topic, and we're very grateful to you, Susan, for sharing your work with us today. Thank you again. And on that note, over to you.
Thank you for the opportunity to present today. My name is Susan. I'm a researcher having recently completed my PhD. I was fortunate to be able to select the topic for my PhD, which was developed through my experience, having previously worked as a physiotherapist and now as a researcher in nutrition. Having this cross-discipline experience has led to health professionals seek my advice on the best diets to help clients manage their chronic musculoskeletal pain. Today, I'll share an overview of the findings from the studies that made up my PhD research, which I conducted within the Alliance for Research in Exercise, Nutrition and Activity at the University of South Australia. My research set out to answer the question, how do dietary patterns and adiposity influence chronic musculoskeletal pain? I was interested in adiposity or body fatness, as it is common for people to be told that they will have less pain if they just lose weight. Additionally, many of you may have tried or been recommended some of these quite strict diets for your musculoskeletal condition. To start, this slide provides an overview of what we mean by chronic musculoskeletal pain, which is defined as pain in muscles, bones, tendons, or joints that persist longer than 3 months. For the purpose of this talk, I will refer to chronic musculoskeletal pain just as chronic pain. Globally and in Australia, chronic pain is a common and significant health issue, with about 30% of Australians affected by a chronic musculoskeletal condition, myself included. People with chronic pain often experience additional challenges beyond the pain itself. These can include weight stigma, increased psychological stresses like depression and isolation, as well as economic and physical limitations. These all influence a person's ability to work, socialise, and engage in physical activity. The impact of musculoskeletal pain, as reflected here, is a significant contributor to disability in Australia, featuring alongside heart disease, cancers, and mental health issues. As you can see in this image, there are several risk factors that can predispose an individual to musculoskeletal pain. These factors may directly cause musculoskeletal pain or influence it indirectly through lifestyles that promote the onset of pain. For example, smoking increases the release of pro-inflammatory mediators in the body. These can worsen pain, while a sedentary lifestyle and lack of physical activity is linked to a loss of muscle mass and power, and we face a greater risk for frailty and obesity. Each of these factors will contribute to the persistence of musculoskeletal pain. The risk factors my research focused on were weight status, dietary intake, and these lifestyle-related risk factors. Weight status and adiposity, which is the accumulation of body fat, are significant. This is because musculoskeletal pain complaints increase with increasing body mass, but also with a longer exposure to excess weight. The mechanisms linking excess weight to chronic pain is related to increased mechanical load and altered forces placing stress on joints. However, chronic pain also extends to non-weight-bearing joints, such as with osteoarthritis of the hands. This suggests another mechanism is involved. This mechanism is systemic inflammation. Body-wide inflammation can be influenced by our body fat. Our fat cells make and release proteins called cytokines. These cause inflammation throughout the body. This effect is greater when we have excess body fat, especially the kind that is stored around our waist, known as visceral fat. And this extra inflammation can contribute to musculoskeletal pain getting worse. This is because the inflammation can sensitize our pain pathways, making our pain tolerance lower, and we experience pain more strongly. When we consider weight loss, pain is reduced primarily through a reduction in mechanical loading. However, a reduced fat mass and associated reduction in inflammation should also be considered. As mentioned, the next key risk factor for chronic pain I was interested in was dietary intake. When looking at a person's dietary intake, what a person eats is influenced by their eating behaviours, such as triggers or motivators to eat. This impacts their food choices. We can then assess the quality of that intake, which indicates how healthy a diet is. And this is important because what you eat can influence your risk for chronic diseases. It can also impact your musculoskeletal health. Diet is also a key driver of weight loss or weight gain, and there's emerging evidence to suggest that dietary components can influence the pain experienced through inflammatory mechanisms. Keeping this in mind, methods that assess whole diets have been recognised as they can provide all the nutrients you need for health and avoiding disease. The way you measure diet quality is through a diet quality tool or index. These can vary across the world. For example, there are tools to measure dietary intake based on a Mediterranean diet. A diet quality tool that relates to our current Australian dietary guidelines is the Dietary Guideline Index. I use this method to score diet quality in my study. It scores a person's intake of core foods, which are those foods that are recommended in the diet, and non-core foods, which are those foods where it's recommended to moderate or limit your intake, such as alcohol and discretionary choices. Higher scores on the Dietary Guideline Index reflect a better quality diet. Considering all of this, I looked at 3 different populations across 3 different studies. Study 1 were a sample from a regional community. Study 2 were adults with overweight and obesity involved in a weight loss dietary intervention. And study 3 was conducted in individuals with chronic musculoskeletal pain. Each study took a different approach to address the question, how do dietary patterns and adiposity influence chronic musculoskeletal pain? So my first study was on a large community sample of people living in regional South Australia. In this population, I had data on what people ate, their weight, waist circumference, and body fat levels, as well as their levels of body pain. We used this data to understand how diet quality influenced their weight status and therefore their levels of body pain. This was done through a statistical approach called mediation, which is a way to understand how one thing leads to another through a third factor, and was designed to answer the question, does adiposity mediate or explain the relationship between diet quality and pain? What I found was there was no mediation by any of the adiposity measures, meaning that adiposity did not explain the relationship between diet quality and pain. However, there was a direct relationship between the intake of core foods with less pain. This relationship was driven by diet quality scores in women, where higher total diet quality scores showed a direct effect on pain. Even though there were high levels of adiposity in this study population and pain levels were higher than the national average, these results highlighted that diet quality itself contributed to lower pain levels, particularly in women. In the context of obesity, these results are important, as in situations where long-term weight loss is not feasible, or even it may not be desired, people may adopt dietary recommendations to manage their pain. However, it does lead to exploring if pain can be reduced with weight loss, and can we reduce pain through improved diet quality? This led to study 2, which involved a weight loss intervention, which was broken down to 2 parts. The first part exploring whether weight loss could lead to reductions in chronic musculoskeletal pain. Men and women were recruited for the 3-month intervention. The diet was designed to meet the Australian dietary guidelines. We used the dietary guideline index score to measure their diet quality before and after the intervention. We also assessed a baseline in 3 months, people's measures of adiposity, inflammation, pain location and pain levels, and functional mobility. 110 participants completed the intervention. We found that chronic pain in adults with overweight and obesity was common, with just over half reporting chronic musculoskeletal pain, so higher than the national average. Participants reduced their energy intake and improved their diet quality. In this study, people improved their diet quality through eating more fruits, vegetables, whole grains, and lean proteins, while reducing their consumption of discretionary foods, which are those foods high in saturated fats, added sugars, or salt, and they also lowered their alcohol intake. 80% of participants achieved significant weight loss. This was accompanied by improved mobility, but there was no change in inflammation. In regard to those who had chronic pain at the beginning of the study, there was no difference in how much weight they lost at 3 months. However, the number of participants reporting chronic pain reduced by half. As the figure shows, spinal complaints were initially the most common and showed significant improvement. There were also significant improvements in foot pain. Presence of multi-site pain also decreased, as did average pain levels. So the presence of chronic pain was high in people with excess weight. But weight loss improvements in mobility did not differ between those presenting with or without chronic pain, meaning the presence of pain did not prevent these people from losing weight. And we found that even small reductions in weight were beneficial for pain levels. Part B of this study explored whether weight loss was the main driver of pain reduction. To do this, we used the same approach as in the previous study. However, because this was an intervention, I looked at whether it was the changes in people's diet quality that led to changes in adiposity that resulted in changes in participants' musculoskeletal pain. What I found, there was no mediation by any of the adiposity measures, meaning that weight loss did not explain the relationship between improved diet quality and a lessening in pain. However, in participants presenting with chronic pain, a reduction in pain severity was directly linked to their improved diet quality. Of note, this was only in a smaller sample of participants where we were able to measure people's pain severity at the same pain site before and after the intervention. Overall, this weight loss study found that improvements in chronic pain could not be explained by changes in weight alone. So while weight loss is beneficial for relieving musculoskeletal pain, particularly in weight-bearing joints, improving diet quality itself may offer additional benefits for pain management in people with excess weight. From this, the next steps would be to conduct a dietary intervention for people experiencing chronic pain. However, it needs to be determined if running such an intervention is feasible. Even though the assessment of dietary intake in chronic pain is increasingly being encouraged by various pain organisations, there's currently limited evidence available for specific dietary recommendations for chronic pain. The assessment of dietary behaviours in people with chronic pain is complex because people with pain report engaging in pain-induced comfort or emotional eating, better called discomfort eating, and overeating in response to pain. As a result, individuals with chronic pain are more likely to engage in negative health behaviours, have less motivation for change, and catastrophise their pain. However, few studies have looked at this. Considering the challenges people with chronic pain face and the lack of clear dietary recommendations, this study aimed to explore the extent to which participants with chronic pain perceive pain influence their eating behaviours and evaluate how diet quality is impacted during pain episodes. We used several methods to assess pain. Body charts, as shown, were used to capture participants' site or sites of pain. We also used this to record the duration of pain, which was used to confirm chronicity of pain. Pain intensity levels were captured with pain scales, and thoughts and feelings evoked by pain were assessed using a pain catastrophizing scale, where higher scores represent a higher level of pain and distress. Again, we assess diet quality using the Dietary Guideline Index, assessing the intake of core and non-core foods. Emotional eating and food-related behaviours were assessed using the Dutch Emotional Eating Questionnaire and a study-specific questionnaire. We had 25 participants complete this smaller study. Of these, most were women across a wide range of weights. A high number of participants reported comorbidities, with osteoarthritis and depression or anxiety the most common. Overall diet quality was poor, with scores averaging less than half of the maximum of 120. And while recognising this was only a small sample size, a lower intake of core foods was associated with higher baseline pain levels and higher levels of pain catastrophizing. Additionally, higher levels of pain catastrophizing were associated with increased emotional eating behaviours. Finally, so I did not influence their dietary intake, we asked questions about people's dietary behaviours in relation to pain at their second visit. Interestingly, participants did not perceive pain as influencing their diet. In response to questions about the diet-pain relationship, the lowest agreement was to the statement that pain medications have altered my appetite. The highest agreement were to the statements, I choose less healthy foods when I am in pain, and I snack more frequently when I am in pain. In conclusion, participants did not see a link between their pain and eating habits, but I suspect they did not realise that their diet was of low quality. This study, however, highlights the importance of evaluating diet quality and dietary behaviours in people with chronic pain. And despite the current limited evidence, there is the potential for considering interventions to improve diet quality as part of a comprehensive lifestyle pain management strategy. What this means moving forward is the importance of developing clinical guidelines for nutrition and chronic pain to guide clinical practice, and recognising when a client's nutritional needs require referral to a dietitian for assessment and tailored interventions. And this is important because, as my study showed, poor diet quality is linked to chronic pain, weight loss may improve pain outcomes, and it may assist in a person's understanding of the links between pain, eating behaviours, and dietary choices. When it comes to managing musculoskeletal pain, it's important to remember that good nutrition is about more than just weight loss, with the overall quality of your diet making a difference to your pain and overall health. Eating a higher quality diet means including more foods that support musculoskeletal health and that are naturally rich in anti-inflammatory nutrients, like your fruits and vegetables, whole grains, lean proteins, dairy, and healthy fats. At the same time, try to reduce foods and drinks that can promote inflammation, such as those high in saturated fats, added sugars, salt, and alcohol. Making these changes can help lower chronic low-grade inflammation, which is linked to ongoing pain. The good news is that you do not have to restrict your diet or make dramatic changes overnight. Focus on small steps that can be maintained over time. Even just drinking enough water is important, as dehydration can actually make your pain feel worse. By gradually improving your diet quality, you will not also be helping your pain, but supporting your overall well-being. Finally, Eat for Health is the website for the Australian Dietary Guidelines. These guidelines offer practical advice on healthy eating and are designed for most Australians. People requiring personalised or specialised nutrition advice can find dietetic support through the Dietitians Association of Australia website or through discussing options with your GP. And the Musculoskeletal Health Australia website provides valuable resources, tips and support, especially useful for planning meals and shopping if pain sometimes makes these activities difficult. Finally, thank you for listening today.